Today, I'm going to be going over the dangers of using psychiatric meds in the treatment of pediatric cases of bipolar disorder. As of the late 90s, children for the first time in history were starting to be diagnosed with bipolar disorder, which up until this point had only been diagnosed in adults. This was due to a series of studies by a group of child psychiatrists at the Massachusetts General Hospital led by Dr. Joseph Biderman. Dr. Joseph Biderman theorized that many children with ADHD were misdiagnosed. He argued that bipolar can be diagnosed in children through the following symptoms: rapid mood swings, tantrums, and explosive irritability. Though this evidence was controversial, it led to an explosive surge in pediatric diagnosis of bipolar disorder. This surge in children being diagnosed with bipolar disorder also led to more psychiatric medications such as antipsychotics, mood stabilizers, etc. to be given to children. The long-term effects of using these drugs at such a young age was unknown, yet many children were given these drugs before exploring other options. In The Medicated Child, Dr. Patrick Brown states, "You have to experiment or let them stay symptomatic," when referring to his child patients. When asked about his wording, he responds by saying that finding the right drugs for a kid at this age is a gamble of sorts, highlighting the risks that come with putting a child on psychiatric drugs. Many children were given a medication to help with one symptom, which unintentionally causes a side effect, which in turn will be treated with another medication. This creates a vicious cycle that can leave some children taking up to 8 medications at one time. This over-pathologizing of symptoms and over-calling them symptoms that need a medication can lead to long-term problems in the child's future. Most of these drugs that are being given to children have only had clinical studies done on adults. When clinical studies were done on antidepressants for children, there was a discovery of suicidal ideations as a symptom, which led to the creation of the black box warning. This warning left many families unwilling to use antidepressants, which led to more doctors prescribing the riskier antipsychotics. Children are physically and emotionally more vulnerable to the adverse effects of antipsychotics because of their smaller size, developing physiology, and negative impact on peer perception, as stated in the antipsychotic medication prescribing trends in children and adolescents. These children are being given riskier medications due to the lack of evidence supporting or refuting the claim that these drugs work. The psychiatric world seems too quick to turn to prescribing these psychotropic drugs for issues that could possibly be solved through other approaches. One such approach could be cognitive behavioral therapy, with specifically exposure and response prevention. In Behavioral versus Pharmacological Treatments of Obsessive-Compulsive Disorder, a meta-analysis, the approach was studied over 5 different SSRIs, specifically for OCD, and the effects were significantly greater for exposure and response prevention therapy over all the SSRIs. All options that are possible should be explored before turning to psychotropic drugs that have unknown long-term effects on children. Thank you.